Chapter 6, Treatment of Bipolar Disorders. As we look at bipolar disorder, we always keep in mind that this disorder is a mood regulation characterized by the cycling between extreme mania, which are the highs, and extreme depression, which are the lows. And of course, that's more of bipolar 1. Whereas in bipolar 2, it's more the client is more hypomanic. But looking at where it originates from, we could look at it as it's endogenous, but it could be triggered by exogenous stimuli. So what I'm saying is that the client could be predisposed to it. It could be due to the biological causes of the dysregulation of neurotransmitters and abnormal permeability of the presynaptic membrane, organic causes that are discussed within your text. However, an environmental stimuli, stress, whatever that client is going through at that time, could actually trigger the bipolar disorder. So that's why we look at it from an endogenous, but also exogenous can influence it. Other things to take into consideration as we look at bipolar disorder is that that medication and other substances may cause or worsen the manic symptoms. And there's a comorbidity between anxiety disorder as well as substance abuse disorder with clients who have bipolar disorder. That does not mean that you may not have a client who has bipolar disorder with another disorder. However, anxiety disorder as well as substance abuse disorder is the most common comorbidity with bipolar disorder. As we look at counseling and psychotherapy, pharmacotherapy is the cornerstone of treatment because, as mentioned earlier, we look at it from an endogenous place. So we are looking at medication as first hand of treatment, and then psychotherapy plays a lesser role. So that's the second treatment or second-hand treatment for individuals with bipolar disorder. It is very important to do a suicide assessment of our bipolar clients because they have a high risk of suicide due to their erratic and chaotic mood swings and behavior. Now keep in mind, with all of your clients, regardless of the disorder, or even if they don't have a disorder, it is very important while you're evaluating them to do a suicide assessment. When we are educating our families, family therapy is very important because we have to educate the families about the disorder. We might provide reading materials on the illness, as well as we could refer the family to their own individual therapy. But psychoeducating family as well as the client so that they can understand the illness, any of the illnesses, even besides bipolar, what will give them a greater understanding of what's going on with them, dispel some of the preconceived notions, and hopefully will guide them to accept their diagnosis and learn to manage the chronic nature of disorder as well as medical compliance. From the family stance, psychoeducating them about the disorder, as well as the importance of medication compliance therapy, it is also beneficial because it helps them understand, which usually brings a little more tolerance when that client is showing symptoms of bipolar disorder. So when they're going through the mania or the depression, or the fact that the family is able to identify it and not necessarily say, hey, you're manic right now, but at least they will understand what is going on with the client and be able to identify so that they might have a plan of action when the client is experiencing the various symptoms. I had a student in one of my classes who missed the first couple of days, and I was contacted by his mother because he was hospitalized because he had bipolar disorder and they had to hospitalize him. And he showed up maybe I think he at least he missed the first night of class, but he came by the second or third week, and as we went through the class, and of course one of the topics was mood disorders, and I covered bipolar disorders. And the mother at the end of the semester, it was probably the semester ended, and a few weeks later sent me an email and thanked me for covering the area of mood disorders, especially bipolar. She said that her son came home and expressed that by learning more about the disorder, and what it is and things like that, that he did not feel like he was a freak or there was something wrong with him, to where there was embarrassment or he was ashamed. So she did send an email just thanking me. But you'd be amazed that although a person might Google all these disorders and get a basic understanding to sit and to talk with you as a therapist, and to gain and to ask those questions, and for you to normalize it so that they don't feel like they're this monster, is very therapeutic and beneficial. Different types of therapy that can be used are psychodynamic, cognitive behavior has been um, beneficial, solution focused, or even group therapy. There are three categories of medications. It's lithium, anticonvulsant or slash anti-seizure, which can be called mood stabilizers, and atypical antipsychotics. Sometimes you'll hear mood stabilizers and they'll throw lithium along with the anticonvulsant, anti-seizure medication. So we will cover the three medications as well as alternate ones that might be used to treat bipolar disorder. What is very important and we need to note is that antidepressants may trigger mania in a client who has bipolar disorder. And what ended up happening is, let's say the client goes to their physician and they're displaying depressive symptoms, so the doctor prescribes them an antidepressant. However, because they may have not experienced that manic stage yet, or they may have and just thought it was just this great euphoric feeling and they didn't report it to the doctor. They're on these antidepressants and all of a sudden the mania is triggered. So it's very important as a therapist, when you hear your client say, and you know that they're on a certain medication, and if they say, well, my doctor put me on this fluoxetine, as well as, but I've been having all the excessive energy, almost like I'm crawling out of my skin. I really don't need a decreased need. I really don't need much sleep. Or they may have abnormal or excessive mood elevation, which is pretty much so how mania looks. That is a note to self, as well as to discuss with the client that perhaps that they are on the wrong medications, because the antidepressant triggered that mania, which is a good indicator that the client is bipolar as opposed to having a unipolar depression. Now, as we look at the medications, lithium as well as mood stabilizers. Looking at lithium, this is considered like the gold standard of treating individuals with bipolar disorder, and it's used to treat acute mania and the maintenance therapy for preventing cycling. But lithium acts as a salt in the body, and we may look at the brand name as Lithobrid, or you just may hear lithium. But with it acting as a salt in the body, what's very important is prior to your client taking the medication, they do need laboratory testing, so blood work, as well as the blood work is done in intervals until therapeutic level is reached. And when I say in intervals, maybe about every 6 months, the client may go into blood work for blood work, because what's also important to keep in mind is that the client could end up experiencing as one of the serious side effects toxicity. But before I talk about the lithium toxicity, let's just look at a few of the side effects: increased thirst and urination. There might be rash, tremors, appetite, weight losses, amongst other things. One thing that you should know, amongst many things about medications, but when we look at lithium, it's not metabolized in the liver and is excreted unchanged by the kidneys, so it's still in its purest form. So what can happen is, if we become dehydrated, it can lead to the kidneys reabsorbing even more lithium, henceforth the toxicity occurs. Some of the signs that a client may have lithium toxicity might be ataxia, poor coordination, slurred speech, poor attention, severe tremors. In rare cases of toxicity, there may be renal insufficiency or failure. What we found, although lithium is the gold standard in treating bipolar disorder, it's less effective when clients are inconsistent with taking the medication. But this is to say that with any of the medications that our clients are on for any disorder, as well as any medical illness, it's very important to have that medication compliance. Pregnant women should consult with their doctor due to the risk of birth defects, if they, of course, have the disorder and pregnancy is there. When we look at mood stabilizers or the anticonvulsant, anti-seizure medications, we may be looking at something in some of the brand names like Depakin, Depakote, Tegretol. Some of the side effects could be dizziness, fatigue, slurred speech, sleepiness, speech problems, nervousness, weight loss. Now, these medications are believed to increase the concentration of GABA, which is an inhibitory neurotransmitter. And by increasing GABA, the electrical activity is diminished and less neurotransmission occurs. So it's perhaps that is what is causing like the symptoms to decrease because there's less neurotransmission that is occurring. So some anticonvulsants, anti-seizure medications may also require monitoring through laboratory testing, as well as pregnant women should consult with their doctors. Now there is a new medication which is Symbiex, and it has the components of an antidepressant and antipsychotic. And what we're looking at is with Symbiex, it works as a depression treatment and a mood stabilizer. So it has both of those components as opposed to the client taking two different medications. The side effects are, as you can see, dizziness, drowsiness, diarrhea, dry mouth, constipation, amongst other things. So this is just very important to see that other medications are coming out and realizes with this bipolar disorder that it might be more than just a mood stabilizer or just an antipsychotic. What can we almost come together almost like with a hybrid kind of medication that might work to treat symptoms? Now, those Symbiex is available, the FDA has regulated that it's specifically for the treatment of depressive episodes associated with bipolar 1 disorder. So there still are some regulations in regards to who might receive this type of medication or who the doctor might prescribe the medication to. As we look at anti-anxiety, we look at the benzodiazepines, and we will also revisit benzodiazepines when we look at anxiety disorders. But such medication as Klonopin, Valium, Xanax, these relieve anxiety symptoms, but as well as improve sleep in clients with bipolar disorder. So if they are feeling anxious, because we know that's a comorbidity, as well as maybe with the sleep disturbances, the doctor might prescribe them a benzodiazepine. However, it's only supposed to be used on a short-term basis. So side effects might include sedation, dizziness, weakness, unsteadiness, etc. As mentioned when I was talking about Symbiex, which of course was the antidepressant with antipsychotic, looking just at the overall feature that antipsychotics can be used to treat bipolar disorders, atypical as well as typical antipsychotics can be used. For example, the Risperdal, Zyprexa, Seroquel, Geodon are atypical antipsychotics that are used to treat more of the acute mania, psychosis, the depressive phase, or the mixed episodes. We will get more into antipsychotics when we start looking at psychosis, which is of course in the, later on in the book. Some of the side effects: dry mouth, blurred speech and vision, constipation, so on and so forth. Now, between the two, physicians are more likely to prescribe an atypical antipsychotic as opposed to a typical due to the extrapyramidal symptoms that clients may experience. So unless it is found that the atypicals are not working, then the doctor may go and prescribe a typical. And the typicals are used to treat acute agitation and for a short-term behavior management purpose. But the reason it's not for long-term treatment is because of those extrapyramidal symptoms, and those side effects are pretty much so very significant. Verapamil is a medication that's typically used to treat hypertension, but in small clinical studies, this drug has been shown to have anti-manic properties. So this is a medication that has been tried in clinical studies and have shown to have the anti-manic symptoms. However, it might not be prescribed as often as the other medications that were discussed earlier in this PowerPoint. Omega-3 fatty acids, through some research, it's found that if you combine omega-3 with lithium, the client's symptoms may decrease, or they've just found that they have in some cases, but of course not all, as compared to a client who's taken lithium alone. Along with that, omega-3 fatty acids have also other great components for a person's health. Finally, electroconvulsive therapy, ECT. We found it in unipolar depression. We're going to find it here in bipolar, amongst other disorders. But you will always find that this is used in the most severe cases, when clients are unresponsive to medication and when suicidality is present. And when we're looking at that, then ECT may be appropriate. So we can definitely not say, we can't say for sure that that is the next line of treatment, but that client may be considered an eligible person to receive ECT.